Imagine needing to buy insulin for your diabetes in a world where the cost of this life-saving medication has increased tenfold in the last decade. $300 per vial of insulin, and many will require multiple vials per month. One day in clinic, a patient described to me they had purchased a garbage bag full of diabetes supplies from a stranger they met on an online community because it was cheaper than going to the pharmacy. There are over 34 million Americans living with diabetes, and despite all of the advancements we see, many do not have access to the education, prescriptions, and support they need to be successful. My name is Michelle Litchman. I'm a nurse practitioner and a health researcher, and my work is focused at the intersection of diabetes, digital health, and disparities. I'm the daughter of a deaf Vietnamese immigrant mother and a hearing father. Not only is my mother deaf, but so are 5 of her siblings. This means that my first job was a child interpreter at the bank, the grocery store, and occasionally medical appointments. When I was 10 years old, my mom required home health nursing. And when my dad was at work, the nurse would have to describe the instructions to me so that I could then tell my mom. This is when I realized that nurses are a type of interpreter. They interpret complex health information for patients and families to understand, and that sparked this interest in nursing. Because my mom grew up in Vietnam, she didn't have access to any schooling. And when I got in high school, she told me that her career options had been limited, but that mine were endless, but only if I seized opportunities. And so my career has focused on leveraging opportunities and taking chances. This is Jennifer Bird. She was my high school anatomy and physiology teacher. She's also a registered nurse. And one day in class, she handed me a nursing school application and encouraged me to apply. And so I took that chance and became one of 4 high school students that matriculated directly into Weber State University's nursing program. I was 17 years old. I became a forensic nurse and trained with I became a forensic nurse and investigated child abuse with an amazing nurse practitioner, Jean Lee Carver. The delicate care that she provided children and their caregivers during this devastating time inspired me to become a nurse practitioner too. I trained with David Windmill, an endocrinology nurse practitioner who forever changed my path from forensics to diabetes care. He taught me so much more about diabetes, and he also served as this excellent role model for how you provide diabetes care to someone. I became a nurse practitioner at an endocrinology clinic, and with that I started seeing that homebound elders were having difficulty getting to the clinic, and so I developed a house call program for them. I described this program to then faculty member Patricia Pierce, who saw this curiosity and innovation, and she encouraged me to apply for a PhD program. I actually didn't know what someone with a PhD could do. I didn't know anyone growing up who had a PhD, and so after taking some time to figure that out, I decided to apply. This is Linda Edelman. When so many people could not see the vision of what I wanted to do with my research, which was combining the online communities and how that could support and augment clinical care, she saw this vision with me and became my dissertation chair and actually recruited me to come to the University of Utah. Wanting a program of research where I could also work clinically, I decided to stay. When you think about diabetes online communities, they can actually augment and support social support. And through the Diabetes Care Foundation, we created this study where you combine a diabetes online community with a continuous glucose monitoring system, and we found this positive feedback loop where one technology supported the other. And we also found that it signals for improved self-efficacy and also diabetes self-care behaviors. And because of this, we won the Diabetes Technology Award at the American Diabetes Association this year. While examining diabetes online communities, I started noticing that people were posting that they couldn't afford their medications, and other people chiming in and wanting to help. And so I led the team. We conducted this nationwide survey, and we identified that people were donating, trading, borrowing, and purchasing diabetes and medications and supplies from one another because it was cheaper than going to the pharmacy. Despite 95% of individuals having health insurance, half could not afford the prescriptions they needed to be successful. One of the things that we found was we exposed this underground exchange of diabetes medications and supplies. And what we called the underground exchange, patients actually called this life exchange. You see, without these exchanges happening, people were left with either a debt or death dilemma. They could go into debt paying for the basics, food, rent, and these costly prescriptions. Or they could ration their insulin or other medications and risk hospitalization or death. This research resulted in several media appearances, including CNN, NPR Science Friday, the doctors. And I also then afterwards worked alongside countless patient advocates and Representative Thurston to put forth HB 207, a Utah bill that would increase access to insulin by instituting a copay cap and also increasing scope of practice for pharmacists so that they could refill prescriptions in emergency situations. And this bill passed in 2020. Another arm of my work is focused on diabetes self-management interventions. Imagine being diagnosed with diabetes and being told the standard phrase, eat better, exercise more. It's actually not enough. People need more education than that, and they need to be able to frame it in the context of their own lives. I'm the medical director of the Intensive Diabetes Education and Support Program, a Driving Out Diabetes initiative that is funded by the Larry H. and Gail Miller Family Foundation. We provide interdisciplinary small group education, and we pack it all in one day. This means you get to see a social worker, a nurse practitioner, a dietitian, and more without having multiple visits and multiple copays. Given that diabetes is managed in this social context, we know that our family and friends can help support us, but they can also derail us when it comes to being healthy. For example, one of my patients described that their family was embarrassed of them having diabetes and didn't want them to check their blood sugar or even take insulin in public, and so they didn't. And this is why we encourage every participant to bring a care partner with them so that they can learn alongside that person with diabetes and also learn how to be supportive. We're having great success with this program. We're improving hemoglobin A1C by 0.5%. That's clinically significant. We're also improving this concept of diabetes distress, which is burnout or I just don't want to do diabetes anymore. We're also improving self-care behaviors such as taking medications or checking your glucose. And this is all having durable effects through 6 months. Now for a moment, imagine that you're living in a rural community where the prevalence of diabetes is higher than here in the city. The grocery store is the size of a large gas station. There is no gym, and you would have to travel for hours to see a diabetes specialist. Through an R56 funded by the National Institute of Nursing Research, we have adapted our interdisciplinary, Intensive Diabetes Education and Support Program for rural primary care practices. We are delivering this in English, but also in Spanish to primary care practices in those rural areas. And given that there's broadband challenges in rural areas, we have this hybrid system where we can deliver directly to the primary care practice, or we can deliver into the individual home. This addresses the geographic, linguistic, and cultural needs of our rural populations. Now for a moment, imagine being deaf, where the data indicates up to 1 in 4 deaf adults is living with diabetes, most likely due to an informational disparity. You see, when a deaf person goes to a medical clinic, only 50% of the time are they offered a medical interpreter. Through the UC Davis Betty Irene Moore Nurse Leader and Innovator Fellowship, we're adapting this great diabetes education program we have at the U for deaf and hard of hearing populations. Most people don't realize that sign language is its own separate language. It has its unique grammar and syntax to English, and someone who is deaf who grows up using sign language, that's their first language, with English being a second language. And when you think about care partners, most deaf people marry another deaf person, but their parents, siblings, and children are usually hearing and may not know sign language at all or have varying abilities. And this is why our intervention will be designed for sign language, closed captioning, and voice delivery all at the same time using telehealth. This will ensure that our deaf populations and their caregivers and care partners will have access to diabetes education in a way that they best learn. Oops. When you have access to the education, prescriptions, and support you need to be successful, it can make living with diabetes so much more manageable. I want to thank all the many collaborators that I've worked with on these projects who have increased access to diabetes to care with me. Thank you.